Good morning, or at least this morning here in the United States. I know it's not perhaps where you are. I am Dr. Joe Roberson, and I'd like to welcome you to a roundtable discussion. Our goal today is to be able to give you information, new information as it emerges in this situation with atresia and microtia. And we're going to focus on new microtia reconstruction prosthesis that we have come up with, the Roberson combined atresia microtia prosthesis. We have people, about over 40 patients, I think, registered, pardon me, today from around the world. And this is the best and the quickest way to get this new information to you. I think you'll find that it's actually kind of exciting and that it's going to be helpful to you and or your children. So here's the format of what we'll do. I can see all of you muted. Thank you. That's great. That'll keep us from having background noise intrude. I'm going to start with a series of slides. We've got about 40 or so slides that will go through some of the data and the information and show you some of these developments. And then we have some questions that have been sent in. You're welcome to email those to us also if you have other ones. I'll cover those questions. And we should be done in an hour, a little under an hour. I'll give you the way to contact me here at the end so that if you have further needs or information, then I will get you that answered for you. We're used to doing that. As you'll see, a lot of patients come to our office from around the world. So we're used to dealing with patients who have questions in our language and in your language. You can write in any language you want, and we can deal with that. All right, so let's jump off here and start. So there we go. All right, so again, Worldwide Roundtable, our discussion this morning will have to do with what we're calling the Roberson Combined Atresia Microtia Prosthesis. That's quite a mouthful. So what we've done is that we refer to that and shorten that to the RCAMP. So if you hear me use the terms RCAMP, that's what we're talking about here. Now, the information that we will give you comes from a number of years doing this. I am in Palo Alto, California, there where you see the red arrow at the California Ear Institute. And this is a map of patients who have come to our office for services, for surgical services, in the last 3.5 years, so 3 years actually now. So we have experience in the last 30 years, or 25 or 30 years that I've done this, in over 4,500 patients. And that represents 75 countries around the US, around the world, that they come here for surgical services. About 10% of our patients actually are from the US, so most of our patients are international. Now let's start with this question, is why do we have two ears? I think it's a useful question. It's one that has a very important decision implications for patients who are afflicted with atresia and microtia. You may know that about 90% of patients who have this condition have it in one ear. And they typically have a normal other ear being normal hearing, and usually normal formation. Sometimes there's a little problem in that ear too, but most of the time that's okay. About 10% of patients have the condition in bilateral. So some of you are looking at this for your children who have no hearing because of the bilateral condition. And then some of you are considering this situation when you have hearing in a single hearing ear. But what does that second ear give to us? Now, I taught a semester course at Stanford University on this exact question. So this one slide is quite a distillation of all of the data and the things that have to do with this. But in grand summary, I'll give these 3 points. And let me stop for just a second, too. You have received a link to a much longer presentation. The most recent one that we've done was in Kazakhstan. And there's a section on atresia, the hearing component, and microtia, the outer ear component. And that will give a lot more information if you want to delve into this, or if you have family members who want to see it. But let's look at these three major functions of two-ear hearing. And the first one is what's called sound localization. So imagine yourself on a football pitch or in a basketball game or just out at the mall, and someone calls your name. The way the function works, or the brain works, is that sound comes into both ears, and there's a timing difference between the right and the left ear. So if sound comes from the patient's right side, it hits the right ear faster than the left side. And it also has a loudness difference between the right and the left. So the brain uses that information to be able to tell exactly where a sound is coming from. And we're very good at that as humans. We can tell within 1 or 2 degrees where a sound is coming from. That has social implications. Most of you have seen, if your child's old enough, if you're at the playground, for example, and you call their name, they hear you, but if they have single sided hearing, but they will scan around because they can't quite tell where you're coming from. The most worrisome component of that is that we see an increase, a 20x increase in emergency room visits for injury. And we believe that's due to not hearing a bicycle coming at you, a car coming at you, and not being able to protect yourself. So that's one that's important. The next two are even more important. And the second one is the one that I see patients the most happy with when we alleviate it. And let me explain that one to you. So the ears are receivers. They take a vibrational energy which comes through the environment. That's what yours are doing right now. And they turn a vibrational energy into an electrical stimulation as the sound goes through the eardrum, the middle ear, and then stimulates the hearing nerve, which is taken to the brain. The ear has an ability to separate those frequencies out, much like a piano has different frequencies along its keyboard. And the brain is actually the processor of that sound. So if you think of yourself in a noisy environment, a classroom or a restaurant, which we've all had that experience, everything that comes to your eardrum or your ear canal is transmitted to the brain in terms of sound. So that can be quite a sea of sound that's hard to function in. It's the brain's responsibility to ferret out or filter out those things you don't want to listen to. And for example, to listen to that person across the table from you who's speaking that you want to understand their speech. In a normal situation, your brain's really good at that. If you've been in a restaurant and the noise is getting a little louder and you're kind of leaning in a little more and you're having to concentrate more on the person across the table from you, your understanding is dropping from 100% in quiet to about 90% in a very noisy environment. If you have a single ear, your understanding is 100% in quiet, but in a noisy place, it drops to about 60% understanding. So imagine what happens in a classroom when inevitably the noise goes up and the teacher's giving verbal instructions, and you as a student get 6 out of 10 of those words correct. It really increases the problems. We see a marked increase in people having to repeat a grade. And that's the one that when, for example, teenagers come back to me, they say, gosh, I can hear my friends now. And that what they're telling me and what they mean is that, for example, in the changing of classes when they're in the hall, there's so much noise. When they had a single hearing ear, they really couldn't understand what people were saying. But now with 2 ears, they can follow the conversation. So that's, I think, probably the one people are the happiest with. Now, as parents, the third one is the one that I would want to understand is that when you have sound from 2 ears, your vocabulary develops at a markedly different rate. And just general strokes, most kids at about a year have 5-ish words. And then by the time they get to be 5 years old, they have 5,000 words. So that 1 to 5 year old age range is really critical in terms of brain development, in terms of vocabulary development. And that's the time period that the brain is set up to learn those things like hearing and noise and directional hearing and vocabulary so that when you enter school at about 5 years of age, then you can succeed. We see, for example, if we study patients in the United States who have grown up with a single hearing ear, on average, their income is 1/3 less than people who have 2 ears. So it's not an insignificant effect. And I take exception. I disagree with a lot of physicians around the world who say, oh, you got one good ear. He hears great. Don't worry about it. Now, the mistake they make is that in a quiet environment, let's say you go see your pediatrician, and that pediatrician says, look, Johnny can hear really well. I talked to him, Johnny, where's your belly button? And he points to it. What he's testing or she's testing is his hearing, Johnny's hearing in quiet. But if you put Johnny in background noise, is when that starts to fall apart. So that's an important thing to understand here. This is what atresia is. So there is a normal inner ear. You see the green cochlea, the balance canals are there as well, but the darker green is where the hearing nerve is. The middle ear bones, there are three of those. They're present in oral atresia. They're almost always malformed, and that malformation can vary quite a bit. And then where there should have been an ear canal, there's solid bone. So the sound, as you can see, there's a potential for the ear to hear because all the inner workings are there, but the sound is blocked from the ear canal. And my goal as a surgeon, is to create this, where there's an ear that focuses the sound down the ear canal. We remove the bone to create an ear canal and build an eardrum. There's no eardrum present in patients who have atresia and microtia. And then that sound energy, the vibration that I'm emitting right now, you're hearing, causes a vibration in the orange eardrum through the yellow middle ear bones and then into the cochlea where it's transcribed and then sent to the brain, as we talked about. So is everybody a question it's we want to ask is everybody a candidate for ear canal surgery? And the answer to that is no. And the reason is because in some cases, the malformation in the inner ear is so severe that it's hard to or impossible to make an ear canal. They're sometimes very, very small. Sometimes the facial nerve, which is the nerve that moves the face on that same side, runs in the way where we need to make the canal. Sometimes there are no middle ear bones. So the question is, how do we decide? And when I first started focusing on this is my third area of focus as a medical professional. In the late 1990s, it was very obvious that we weren't very good at answering this question. And some of the literature, if you look back, is really confusing because some of the patients have really good results and some of them had bad results. And we didn't know why. And I think the reason why is we really had no way of categorizing people in terms of the potential success of their surgical candidacy. So this is a system that I developed. We published this in 2013 that looks at the acronym HEAR MAPS, HEARMAPS. It's not important that you memorize this, but what we do is that we gather this data in each patient to be able to say to you, we look back on our 4,500 plus patients and we say, patients with the same grade as you have, here's the chance of success. Here's the chance of hearing improvement. Here's the chance of normal hearing. Here's the chance of having to use a hearing aid or something else afterwards to get the hearing that we want. So you'll see us gather this data before we say yes or no to patients. Now, of 100 patients we get, the majority of them are candidates, but not all of them are. If you are not a candidate for an ear canal, then there are other options. But since a native and normal functioning ear canal gives the best function, that would be my goal or my desired thing as a parent to have. This relies really on two pieces of data that you have to send to us. One is a hearing test. It's called an audiogram. And the second one is a CT scan. And I can look at the CT scan and I have a system where we give points for things that are present. For example, is there enough room for a canal? Is the facial nerve in a good position? What do the middle ear bones look like? Is the inner ear normally formed, et cetera? And that's a 10-point scale. And the higher the number is with that, the better the chance of success. I read all of those personally. I will not operate or advise a patient unless I've seen the scan personally. So that's, if you're interested in evaluation, that's one of the things that we will do next. If you want to read that paper, if you're a medical professional, someone who loves to do that, just take a photo of this slide. This is the article itself. This is actually, since it was published in July 2013, this has been by far the most read and quoted piece of literature on atresia and microtia. Now, this is really complicated, and I don't want to have to make your eyes go round and round in your head to see this. The basics of this are, we get the CT scan at 2.5 years of age. The ear grows quite a bit between 0 and 2.5, so we need to let it develop a little bit to know if a patient is a candidate. If the patient has a grade of 6 to 10, then there are several options for us to make an ear canal and to reconstruct the outer ear. You see those down here at the bottom. The two that we're going to function or focus on today are here, this one, the combined atresia microtia, and the canal, and then the outer ear afterwards. I'll also mention rib graft as a possibility, but that one is less selected. It's still possible, but it's one that patients don't use as much these days. All right, so now, what options do we have with microtia? And the first one is what's called a prosthesis. If you think of the movies that you would see, for example, from Hollywood, there are a number of people who are very talented at making things like masks or horror movies that make unusual things to do with the face. Well, that same skill set can be used to make an outer ear. It's a rubbery, flexible ear. Sometimes that is held on by a two-sided tape or glue. So the patient gets up in the morning, glues their ear on, and that can look very natural and can match either the family's ears if you're bilateral or the other ear if you want that. The downside of that is that it can come off. It's not a permanent solution, and that really ignores the hearing. But that's one of the microtia things that we can do. The second one, and this was when I first started doing this was what we used 95+% of the time, is a rib graft. And a rib graft uses the patient's own rib. We harvest that from the chest wall, and then we wire and suture those ribs together and carve them in the operating room to make an ear so that it looks like a natural ear. The surgery has to happen later in life, as you'll see. And that one is not as exciting to me because we don't typically deal with the hearing until after the rib graft surgery is completed. And the average age in our population of all the patients I did early in this journey was over 11 and a half years of age. You may remember I said that 0 to 5 is the real time where hearing and brain development happens. And that's medically, we call that a critical period of development. So we would have missed that critical period of development if we wait to 12 or 13 or 14 at the earliest to provide an ear canal. Some surgeons have moved that earlier so that we can do an ear canal by the time they're 8, 9, or 10, which is good. But the limiting factor with the rib graft is we have to wait for the child to get large enough for the rib to grow enough to actually make an ear. So I don't think we'll be able to go much younger in age. The last one is to use a man-made material, and there are a lot of materials that we implant in the body. Titanium is one, hips, for example, and those sorts of things. We use materials. There's a whole list of them. But the one that has been the most useful is PPE, or porous polyethylene. And that is a relatively biocompatible tissue. It means the body doesn't have a strong reaction against it, but it requires a different surgical technique. We have to do a tissue flap and skin graft coverage over the top of the implant. So I think someone may have come on whose microphone is not muted. If everyone could check to see, we're getting some feedback there. So microtia techniques, the rib graft takes 3 to 4 surgical procedures. Typically we start at, in the 6 to 8 year range, and then we finish by, as I said, 11 to 12. And then the canal surgery is after. Whereas the porous polyethylene, the minimum age that we do the surgery is 3 years of age. And one of the advances that I've made in my career is that we change the order, or can change the order with this technique, where the ear canal can go first, and then the outer ear reconstruction can happen 6 months later. We first started doing that in around the late 90s or the beginning, around 2000, where we did the ear canal surgery first and then the outer ear. Or the other option is that I developed in our office with some other surgeons, something called a CAM, a combined atresia microtia repair, where we do both the ear canal and the outer ear at the same time. That surgery, the first ones we did there were 2008. And as you'll see in a few minutes, we've done quite a few of those over time. So those are the two options, 3 options really we use. There are some surgeons that are quite good at rib graft, and patients from other countries typically will select that as their outer ear reconstruction method, and we'll be happy to do an ear canal with that. But there are some upsides and downsides. So I'll show you on that in a chart here next. So if you look at these six characteristics, what I've done is try to list which one has the better effect. The age of surgery I've mentioned. 3 years of age for PPE, we can get the hearing in, which has great impact in terms of development and those three functions that I mentioned to you. Rib, it's later, as you know, in early adolescence. That impact on development is large. The thing also about a critical period in humans is that you have a period of time to intervene and to restore function for development to occur naturally. If you don't intervene during that time period, then the brain doesn't have the ability sometimes to go back and relearn that. And I'll give you a concrete example. I have an accent that in the United States is people can hear me talk and they know that I'm from the southeast or the eastern part of the United States. My brain heard in my family and the people I was living when I was living around them pronounce words a certain way and say things a certain way. So once you get beyond that critical period of development, trying to change your accent is really difficult to go back. So that's just a concrete example of how that critical period can impact things. I also think that the PPE is a much more natural look, and mainly it's because the ear will have projection, so it's not flush against the head, which a lot of the rib grafts are. Both rib graft and PP are very hard. We wish, and I hope that in time in the future we'll have that. We wish we had a prosthesis that had flexibility like a normal ear. That it's like cartilage that will move. But the PP and the rib are both rigid. The rib is an advantage with natural tissue. Any man-made material, you have to be very careful with that, and you have a higher rate of complications or problems from that than you would a natural material. So there's an upside to rib there. And the cost of the PPE is less. And that's mainly because there's typically one or sometimes two surgeries with that, whereas the rib graft takes 4 or 5 surgeries by the time you get the outer ear done. And then it's usually 3 or 4 for the outer ear and then one for the ear canal. So there's a big difference between the two of those. All right, now I'm going to go back through some of the implants that we have used over time. And let me just give you the sort of setting of what has happened over time is that when I first started doing this, I worked with a number of different plastic surgeons over the years, and pardon me, the plastic surgeons made the decision about what implant we used and how that was constructed, and sometimes they worked with companies to make these. And that's changed now, as you'll see. I'm now focusing on the outer ear implant as well, but this is the first one. It's called MedPore. You'll still see a lot of people around the world call the outer reconstruction MedPore reconstruction, and that's because this was the name from a company called Porex that was given to that. It was a two-piece implant. So there was the Y-shaped piece and then the rim on the outside. And the good thing about that is it allowed us to tailor the size of that implant to match the other ear size-wise and contour-wise in the operating room. What we didn't understand at the time is that those connection places where we welded those two implants together very frequently broke over time. So as we started to use these several years later, we would realize that the microtia implant is not functioning correctly. It's malformed, or it's maybe even threatening to come through the skin, or has come through the skin, and the plastic surgeons would need to revise that. So they decided to go to a different type of implant, which was a single piece implant. There are several of those we've used, but one of the more recent ones is from a company in Australia called Anatomics, called Starpore. It was the implant looked good; it was a good shape, but the problem is when the implant was put in, and there were a lot of those put in. Actually, most of them not in my office, patients who had just the outer ear reconstruction, but we had some as well. In about somewhere between 4 to 15 or 16 weeks, the body seemed to have a strong reaction to the implant. So the skin started to get swollen, it started to get red, it was malformed and malshaped. And what happened is that the FDA actually removed this implant from the market, and all of those had to be removed. I think all of them now have been taken out. If not, a very high percentage of them. And they had to be replaced with a different implant. It's the same material, so that was very concerning for us to us for a while. So what is happening? But it turns out that the way the implant was sterilized had a different process and a different chemical than had been used before. I believe is what we think is going on there, but that is no longer used. So after that, we went to a company, and again, this was. The plastic surgeon's decision was a company called Matrix Surgical, something called Omnipore, and that's the most recent implant that we have used. I have a couple here. Once we're done with the slides, I'll hold them up and show them to you. And what we've seen, sadly, is that over 20% of those implants, actually almost over 25% of the implants, if you look back from July of 2021 to 23, which we've done, have broken. And recently, there have been just a rash of broken implants, and that is heartbreaking to me because we have, let's say we get good ear canal and good hearing, and the outer ear looks good, and then suddenly the child wakes up, or parents notice that the implant is fractured. I'll show you what that looks like, and then some of them were, we know what happened. They fell off their bike, something like that, and some of them, in fact, most of them, it just seems to happen by itself. So that one is very concerning to me. So here's an example of what some of those look like. This is a young boy. These are all pictures sent by parents. So if you look, there's a fracture here and there's a fracture there. You can see that there is like a crease in the skin and not a normal contour there. Here's another one. It's fractured and pulled back against the skull, and you can see right here that there is an exposure. Actually, the implant is coming through the skin. You'll see this one, a surgical example of that, in a little while. Here's another one, not the worst in terms of the way it looks right now, but there's still a fracture here. You can see a fracture there, and right here, you see that's not a natural contour. So that implant is beginning, because of the sharp edge where the fracture occurred, will eventually come through the skin and will need to be replaced. This one has actually that happening. So you can easily see the fracture up here. And here's where the implant is coming through the skin. I think you're getting a sense of what these are. Here's another one where the implant is working its way because of the fracture through. It's hard to see from this projection, but the ear is pushed back also against the head. So the back portion is broken. And this one's very evident. You can see that the back part of the implant is really too far posterior. Another one, you can see easily the mom has marked, or the parents have marked the fracture at the top. Okay, so here's one. You see a step off, so the implant comes like this right above there. So you can tell this is not the good way to do it. So in the practice that I've had over time, we've had a cardinal principle, if you will, to find a better way. And when we first started doing the ear canal surgery, it's of all the surgeries we do, I believe that it's the hardest, and it's the one that I think we got the worst results with. So over time, what we've done is focused on a way to improve different aspects of that. And today, all of my efforts have been focused on the hearing and the ear canal component. But because of this recent change in the implant performance, this is the first time that I'm now focusing also on the microtia reconstruction, and particularly on the prosthesis. So I won't spend a lot of time on this, but these are the things from the ear canal that I have done, we have done, or pioneered at the California Ear Institute. And I mentioned the first one. We were the first place to perform atresia surgery before the outer ear. We were the first one to perform the combined atresia microtia repair in 2008. The HearMap system you saw, we have a way of doing atresia surgery. We make a very small scar, which is obviously much preferred. We found in a number of patients also that there was a malformation between the second and the third bones of hearing. And it was so small that you couldn't see it with a microscope. And one of my trainees did a marvelous research project where we used an endoscope, which had a magnified camera on the end, and we looked very closely at the middle ear bones. We found that a third of them had this malformation. And if we did not fix that, then we would not get good hearing. So that was one of the things in the older literature, I think, that people had not recognized as to why some people's hearing didn't get much better. So we came up with some reconstruction prosthesis for the middle ear bones. We typically know if there's a chance of having to reconstruct the middle ear bones before going to the operating room, but we never know until we're actually able to look at those middle ear bones in the OR. Some patients, we can tell you you're going to need middle ear bone reconstruction. Some patients, we say we don't think so, and we get in the OR and no, we don't. And some people, we say we don't think so when we get into the OR, and lo and behold, we do need to reconstruct it. The good news is that when we do that reconstruction, we get hearing that seems to be as good as the normal middle ear bones. Sometimes it's even better. The only downside of that is that the chance of the hearing deteriorating over time is slightly higher with the middle ear reconstruction than it is with the native middle ear bones. But that's still very worth it because we wouldn't get good hearing if we didn't use that reconstruction. We've used a skin graft that comes from the scalp. It's fortunately the best quality skin and the most like a normal ear canal. That's the skin graft for the ear canal. And it doesn't leave a scar. There have been some terrible scars over the years on other body places, the thigh, the backside, sometimes the arm. And then the last one I see on the list is that I noticed when we were doing the combined surgery that over time with gravity, the outer ear would begin to move down. And it could move down to the point that it actually can close the ear canal. And it would sometimes require a second surgery to lift it and secure it. So I came up with a way to secure the PPE implant in CAM surgery, and that's basically stopped that problem since then. But what we're going to, each of those is a separate lecture, but what we're going to talk about today is the CAMP microtia reconstruction prosthesis, which I hope will solve some of the problems that we've had with this. So when you're doing that, I've worked with a number of biomedical companies over the year, about 20 actually, for all kinds of different things in medicine. But what you want to look for is you want to have the best biocompatibility of the material. Excuse me. And I think at this point, the PPE is that material. We also want to have a company that has used it for years. You don't want a company coming out with their first version of something. We want a company that's stable, that's economically viable, it's going to be around a long time. And you also want a team that's capable of producing a new product. And invariably, you do your best with the product that the design that you have. But after you use it for a while, you'll find little things that you want to change about it. So we want someone to be responsive to future product revisions. For example, with the new prosthesis here, I'm on the fifth revision that we have used. The 4 of those have occurred before we implanted the first one as we try to perfect it. And then there's a small one that's coming next. Supor, the company is Periferous, but Supor is the material, is in Noonan, Georgia, in the United States. And that company is the one that I've selected to work with.
Now
so
you're going
you
to
see
see
here,
some drilling in this implant.
I'm in the office, that's
the
drill
in the operating room.
that allows
It's a
us
2
to
millimeter
take a
burr,
block
if you can
of
see
porous
that there.
polyethylene
And what
and
happens
really
is
to
this
carve
device
that
here supplies
that's the
power
portion
to
of the device
drill,
that
and the burr
that
itself
provides
will
power
allow
to
you
it.
to
So we
sculpt
can
the implant
make
into
our
what you
carbon
want it
ear
to be.
in the exact shape that we want. As you may know, as you may surmise, we need different sizes. And I'll talk about that in just a minute. But I've worked with a gentleman named Spencer Jones, who's a delight to work with and very talented at coming up with this design, which I think looks more natural and is much less likely to produce the complications. And this is what that implant looks like. You'll see that more so in just a minute. And it is very similar. For example, if you were working, let's say someone donated their body to science and you were working with that afterwards, if you took the cartilage out of a normal ear, that is almost exactly what the cartilage looks like. That's quite different from what we have been using before. So here's some photos from the OR, and there's nothing here that is very offensive, I think. You'll see 2 implants that I've removed. There's a little bit of blood colored tissue attached to them, but it's not, I don't think it's too bad. If that bothers you, feel free to obviously grab a cup of coffee or something for a moment, but I just want to warn you that that's coming. So this patient you saw earlier, this was an omnipore implant, single piece, pardon me, she's 7 years old, and she'd had the CAM surgery 2 years previously. Her hearing is wonderful, actually, and very stable, but she has a fractured implant and an exposed implant. So we needed to return to the operating room to take that implant out and to replace it. And then we replaced it with the new implant, the Roberson CAMP. And this is her implant as it came out. You can see that there's tissue that goes into this porous polyethylene. That's good. It makes it more biocompatible. And as I touch that, there's one fracture. Here's the other fracture here. And then you can see this posterior rim. It shouldn't be rigid. It shouldn't move. But that is a broken implant. And with the body's healing, it pulls that back and against the head. And that force, I think, is what has broken this. So that's the typical way an implant looks when we remove it. And here is the ear replaced with the RCAM. Same patient and in the operating room. And you can see that there's projection, so the ear's away from the head. We were able to keep the pocket of skin intact. And there's a sponge, a white sponge in the ear canal that's just holding that area open. We didn't need to do anything to the hearing or the canal to replace that. Here's another patient, very similar, 2 years prior. This patient had had a second surgery by the plastic surgeon to replace the implant that was fractured. And she returned with it fractured again, the same implant, and also with exposure. Again, her hearing was excellent and stable. And then this is the implant that was removed. And I think we have some sound on this one, so I'll let you listen to that.
And here. And this is where the weld was made.
I don't know if that's coming through, actually. So let me, you know what, I'll go back here and narrate that for you. Okay, so here we go. So that's the implant that came out. There is a fracture. There's a fracture. And there's a fracture. And this is an area where the surgeon tried to weld some material into it to make it stronger. This implant has, the last one had openings or holes in it. And here is the RCAM prosthesis. You see it's a single piece, doesn't have the holes. And if you look at it on the side, the prosthesis is much stronger on that posterior rim. Smith, the man I worked with, told me that his way of determining if these are strong enough is that he stands on it, and which makes me kind of laugh a little. But that would crush the implant to the right, and it does not crush the one on the left. That view shows there's very little implant behind the rim in the first one. And then on the second implant, there is more that allows there to be projection and to maintain that projection over time. So here is the second patient that we're showing what the ear looks like in the operating room with the video. The ear canal, we didn't have to do anything to, and the earlobe, we didn't have to do anything to. So you see there's a little swelling, a little redness, which is expected, and that will go down and the ear will become more defined over the months following surgery. And I think that's going to have a very good look. Now, just because I may anticipate a question here, I'm going to show you a patient who had primary surgery. In other words, this is a surgery that I did with, there's no revision. This is what the patient started with the CAM, the combined atresia microtia. And this is August the 15th. You see the small malformed ear. The red dots are the blood vessels that supply the tissue layer between the skin and the scalp. We carefully dissect that out and then bring that over the top of the implant. And then the skin graft goes over the top of that. So you can't put a skin graft directly on the PPE because there's no blood supply to keep it alive. Whereas if you transpose the flap over the top of the ear, then that will keep it alive. This is what the ear looks like in the operating room when we are finished. It is one that is a little smaller to match his other ear. The earlobe down below is just rotated in position. It's not detached, so we save that. The skin on the front of the ear came from the original malformed microtia ear. I remove that and save it, and we use it on the front because that has the best color match. That'll be the same color as his cheek, for example, and that won't be natural. And then there's skin in the back of the ear in the crease. That skin comes from where the leg joins the body. And that skin is it's robust. It has it's not seen as much, so that's why we put that there. So the color match is what is good. And you can't see it right now, but the skin from the ear canal was the graft that we took from the scalp. We take a very thin graft there so we don't transplant hair into the ear canal. That would not be a good idea. And that allows where the scalp heals, it heals without scar. I don't quite know why that's the case, but it's fantastic. The hair grows back through the area because we leave the hair follicles. They're deeper. We take a very thin graft. And that area heals itself and is fantastic. And it's covered once the child's hair grows back, which is great. Now, this is the 15th day after in clinic. We put a mold on. You see that blue mold that I make in the operating room, and we suture that in place so it can't come off, so that it's protected. And then day 15 is when we are removing that. And here is the first unveiling of the ear. You see a little bit of crusting, as you can imagine. We're cleaning that off. The sponge is still in the ear canal, and the skin graft is pinker than normal skin, which is normal. It'll actually get bruised, as you'll see here in a second. And then there is day 21, 1 week later. The color changes because the body is starting to connect the blood supply from the flap to the new skin grafts, which is exactly what we want. So it gets darker. There's a little bit more dusky redness to it, and then that skin color will come back exactly the same as the cheek. It takes about probably 8 or 9 months for all of that to happen, but usually within 3 months after surgery, about 90% of that healing is done. So that's sort of the time course that we would see. And this is day 29. In the clinic, you see the skin starting to get a little bit more normal. We have some antibiotic ointment that the parents are keeping on the ear so that that will heal well. And then this is the result from the patient. He lives 7 or 8 thousand miles from California Ear Institute. So this is a photo sent by the parents more recently after he's back home. I think the skin, you can tell, looks even better. Earlobe looks nice. It needs a little cleaning, to be honest with you, and we would instruct the parents to take a little gauze and to clean off some of that extra skin. But that's what it looks like when we do the combined atresia microtia. So, in summary, what we see here, I'm going to get to a couple of questions after that, is that this implant is much more fracture resistant. We had a nightmare for me. A patient that we did, one of the last surgeries we did with one of the surgeons we used to work with the plastic surgeons, and went home to Russia, actually, a small town in Russia, 2 weeks after the surgery. We had excellent result, and the implant broke. So I hope that's a thing in the past. I also hope that this one will have a more natural shape. It'll come out from the head more than the previous prosthesis. And the way I've designed this is I can change it actually in the operating room. So some patients, as you know, some family members, their ear sticks out a lot, and some does not much at all. So we can tailor that so the two will be closer or have a higher chance of matching. The biocompatibility we've talked about. And then this one really can be used either for the simultaneous surgery where we do the canal and the outer ear at the same time, or we can do the canal first, let that heal, and then 6 months or more later, the outer ear surgery can be done. A couple of resources, and then I'll address some of these questions here. My daughter Haley, you see her in the bottom left here in this, and I wrote a book for parents called Atresia Microtia in Your Child. And it goes through at length, I think it's 125 pages or so, each of the issues and touches on them in much more detail. That's available. It's available on Amazon, for example, if that's something you can get in your country. It's also, if you have or you want that, you can talk to our office or give us a shout. We'll tell you how to get hold of that. And then we've done quite a bit of work with our website to put information there. You can find, those are where the links I think were embedded that we sent you before. You can find at atresiamicrotia.com a wealth of information. And at the bottom, snap a picture of that if you have your phone with you. Atresia Repair at CalEar is the email that accesses our system. I and my team answer emails every day, a lot from around the world. And we answer things from, okay, I had surgery with you 8 years ago. My child has an ear infection. What do I do? Basic sort of question, all the way to my child is 2 years old and has complicated medical history and bilateral atresia microtia. What do we do first? So anything in between, that's where you start and how you get going there. You might hear some noise in the background. It's raining here very hard, which is unusual for us. Okay, so let's go back. And if you have questions, feel free to send this to us as we're going. But I have quite a few here already, and we have about 15 minutes, so that's about right. So the first one was, how many CAMs have you done? The first surgery that I did was in 2008. And by the way, when they say CAMs, they mean the combined atresia microtia repair. So I've done over 4,500 ear canals, but a subset of those are patients where we did the ear canal and the outer ear at the same time. First surgery was done in February of 2008 in my office. I've worked with 3 plastic surgeons since that time. And we've done now over 650 of those implants and procedures for patients. The RCAMP prosthesis, we've now used that in about a dozen patients. So it's early in its lifespan. So far, I'm very happy with it. I don't see any complications or issues or anything near what we had seen with the other one. The next question, how do you know how big to make the ear? That's a really excellent question. So in the 1970s, there was a very nice study that was done that looked at children. Well, the word we use medically is longitudinally. So they started at 1 and followed them all the way through until they were adulthood. And it shows how quickly the ear grows. So we have a chart created from that so that we know, let's say a child has surgery with us at 4 years of age. Then we know that that ear on average is about 91 or 92% of an adult ear. So ears grow early in our lifespan, much faster than the body does. But if the implant that we put in, if we make that about 7 or 8 or 9% bigger than the other ear, then we know as the child grows, they'll be the same size. The implant doesn't grow, as you might imagine. So at first, the reconstructed ear will be a little bit bigger. And people have different size ears, me included, as time goes by. So the key with this surgery is, I'd love to say we can get it to the sub-millimeter level, but that's very hard to do. But the question or the key is to get it to a point that you don't notice it. It doesn't draw your eye. You see, when you look at a child, you don't your eyes don't go to that ear and say, what's happening over there? So that's something that with that chart, it's invaluable for us to do it. Okay, here's a good one. I'm glad you asked this one. Do you receive royalties or compensation from SUP or for the RCAMP? The answer to that is no. I feel strongly that the surgeon should not get financial compensation to use a certain material or some supply from some supplier. I want to make that decision based on what's best for the child. I almost always, my office staff gets tired of hearing me say this. I make the decision with one question in mind: what will you do for your own child? And that's a really simple way to make that. So no, we don't have any influence from that standpoint. So is this a 3D implant? The answer is yes. This is one that's designed in a way that has 3D structure. Next question, does any other surgeon do canals and outer ear reconstruction at the same time? So I'm not aware of a single surgeon that does both around the world. There are some teams that are starting that are trying to do both the outer ear and the ear canal at the same time with a plastic surgeon and an ear canal surgeon. Here's a good one. What does the future hold for microtia reconstruction? I think, well, this is a little bit of a crystal ball question. So take what I say with a grain of salt, because it's my best medical guess. I think that you will see over time that this will evolve to a point they're actually able to take a patient's cartilage, a biopsy of cartilage. That could come from the other ear, it could come from another place. Like, for example, the septum of the nose is an easy place to get cartilage from. And I believe that we would be able to take that to a lab, grow that up into a large amount, and then to make an ear that's a mirror image, if we have a single-sided situation, of the other side that's flexible and more biocompatible because it's the patient's own tissue. We've actually worked with folks to do that. The problem is we can make an ear, but it's gelatinous, it's sort of soft and rubbery, and we don't have a way right now to keep the structure of it. When it's been implanted in adults, what happens is it tends to kind of fold in and almost melts down to like almost a gummy bear looking situation. But that I think is where we'll go. There's a lot of work being done with recombinant technology right now, especially where we are in Silicon Valley. And I think we'll get there. I don't think that's going to happen quickly, sadly, for two reasons. One, it's a complicated process, it's expensive. And second of all, in the United States, people work on things where there's a really large market because they can sell a lot of the product and there is a way to recoup their investment. It typically takes about $70 to $90 million to make a device like that in the US. So if you have a lot of patients, like for example, a knee prosthesis, a lot of around the world, that's a huge market. Then people are motivated business-wise to do it. The atresia microtia population is a small population. So I think we'll probably be later from that. My guess is 10 years or so from now is when that's going to be about the time it'll come into play. But as a parent, I would say, well, should we wait for that or should we go forward now? And what drives that decision is the hearing status, because we want to get hearing in during that critical period of development. The outer ear, fortunately, you saw a couple of examples of how we can take an implant out, put another one in. I think there will be a time when patients who have a totally normal functioning ear that we've made, who have the PPE, say, I would rather have an ear that does this and feels more natural. So can I take the PPE out and replace it with a recombinant ear? I think we will do that at some point. That's a whole other discussion. Taking something that's working and changing it is, that's a tough one. But I think that's where we'll go. But I think in your situation right now, it's far enough in the future, it probably doesn't impact that decision right now. Okay, does everyone get good hearing? If not, what are the next options? Good question. So here's what I would say is the higher the score on the CT scan, the better chance we're going to get good hearing. Fact number one. Fact number two, almost everyone gets improved hearing. Fact number three, everyone does not come into the normal range. For example, if you have a score of a 7 or an 8 on your CT scan, then 80% of those people will come into the normal range. It's normal. It's never quite as good as a normal ear if you have a normal ear on the other side, but it's very close. And then the other 20%, we either have to do a revision surgery in a small percentage of patients or use a hearing device, or sometimes the two ears together are enough to provide normal function. So that's, for example, those are the statistics. Once I see your or your child's hear map score, then I can give you specific statistics for your individual situation. Here's a great one. In fact, we may do a whole conference on this one. Why not use an implantable hearing aid? So implantable hearing aids, they take advantage of the fact that you can take a vibration and connect it to the bone, or the device is actually connected with a titanium screw that connects to the bone. That vibration goes through the bone, bypasses the ear canal and eardrum, middle ear bones, and goes directly to the inner ear. So that's a good solution. The downside to it is that it's a mechanical type sound. The bigger issue is that when you put the implant in, it sends a signal to both ears. So you don't have the data on the two-ear data stream to improve directional sound, or you don't have the data in the two-ear data stream to improve hearing and noise. So for example, children who get in a noisy situation almost always take their bone conduction or implantable hearing device off because it becomes counterproductive. Now, there are some people that's excellent to use because that's the best option that you have. But when you compare a bone conduction or implantable hearing aid to an ear canal is head and shoulders better if you're a good candidate for that. The reason I say we may do a conference on this is there are surgeons around the world who say there's no difference, and that is not true. Those are plastic surgeons, and we'll talk about it later. What is a cholesteatoma? Okay, this is someone who's done their homework, which is great. A cholesteatoma is a tumor that forms where the ear canal should have been. When a child develops in utero, the way the ear develops is there is a small pit that develops on the outer part of the ear, and that pit dissolves down in a tract At the same time, a pit from the back of the throat comes up through the base of the skull, and the two dissolve toward one another. The middle ear bones are left, they don't dissolve away. And the two meet, and the ear canal is left. It's astounding that it works. I mean, if you think about all the complexity of that. But in some patients, that little bud will form, the tract goes down, and then the ear will close off, and the ear canal stops developing. So you can get skin buried where the ear canal should have been. The skin lining continues to make skin, and it sloughs a layer of skin that over time begins to put pressure. There's a cyst or tumor that's there, and that tumor enlarges and will erode the bone. Over time, in the lectures you got, or there's some examples of these, that can actually erode to the point it gets into the inner ear, or worse yet, it will develop into or grow into the brain. Every patient, this is capital letters if I could do that here audibly, every patient needs to have a CT scan before surgery. Not all plastic surgeons do that, so be careful. I have a bunch of patients who have been sent to me, have had an outer ear put on, no ear canal or no hearing focus, and then 3 or 4 or 5 years later, something is pushing the ear up, and they go, "What's happened?" And then they get the CT scan, and we find the cholesteatoma. So even if you're not going to do an ear canal, absolutely, please get a CT scan. And if our website has it. If you want to email us, if you're like, what scan do I get? What do I ask them to order? Contact us and we'll tell you, so that you only do that once. Make sure that you get the right scan. Okay, let's see. There's several. We've got just a couple minutes left here. Okay, I'll do these 3. What's the earliest a child can be evaluated? 2.5 years, sometimes down to 2, is when we like to see a CT scan. And the earliest we do surgery is 3 years of age. Child needs to be healthy. We like them, if they can be, to be 15 kilograms. And the principle is safety first. We need the good score on the CT scan. And then the earlier we can do it, the better. I would, for my own child, or now my own grandchildren, I would say I would not wait beyond 5 years. We still can do it. In fact, the oldest person I've ever done is 64, but the best results are in that 3 to 5 year age range. And what's the chance of another surgery being needed? That's a great question. So for the ear canal, over time, we see that the chance of revision surgery being needed, we think, is about 10%. That new ear can have some of the things happen to it that a normal ear does, like an ear infection with a perforation. But there is a higher rate of a reconstructed eardrum compared to a normal eardrum, something happening. So that's about 1 in 10. The patients, I mentioned the July 2021 to 23 group of patients. It's really surprised me. I went to one of the plastic surgeons we were working with at the time, and I said, "What is your complication rate among these patients?" And he goes, "I have no idea." So, okay, I think we need to know. So we looked up all the data, and the outer ear reconstruction revision rate is over 50% in those patients. So 1 in 2 go back to the operating room. That's not good. And that's why I'm focusing, I'm bringing that find a better way philosophy to the outer ear. And I think this is a big advance, to be honest with you. So what is the cost? How do we do that? I'll cover that. All the fees are, when you add anesthesia, the OR, surgeon's fees, medications, all the things included, it's just over 100,000 US. And then to reserve a date, we have to see your HearMap score. Once I say that patient's a candidate, then we talk to surgery schedulers, and then when you make a deposit on a date, that date becomes yours. That's how the system works. Last question, how long does a combined surgery with the RCAMP take? And the patient comes to the office. We give a medication that they drink that makes them very sleepy and also takes their memory away. So they'll remember getting in the car and coming to the office, but they typically don't remember anything after that. I take the child into the room. I love to actually carry the little ones when they're under 50 pounds or so, and we put them to sleep at right around 7. It takes us about an hour to get all the monitors and everything else in place, and surgery starts about 8, and we typically finish at 1 to 2 o'clock. Patients go home the same day. It takes about an hour or hour and a half to recover. And you go home with pain medicine, antibiotics, and all the medications and supplies in a bag. And then we see you back a day or two afterwards to make sure everything is in place and change the dressing. And then we see you weekly for 3 or 4 weeks. And then typically you're on the ground with us for the combined surgery for 4 weeks. For the ear canal only surgery, we ask you to stay with us for 3 weeks. Okay. Actually, let me cover this one before we're done. It says, can you operate on 2 ears at once? We don't like to. And the reason is because we want to see one ear without any complications. One of the rare, but I think one of the scary things is that you can see an injury to the hearing nerve with surgery. So you could potentially produce an ear that doesn't hear with this. Fortunately, that happens at way less than 0.1% in our experience, but I want to have one ear here healed before we do the second one. There are times when we, for example, if there are cholesteatomas in both sides that we find and they're threatening, then we will do both at the same time. So it's been done, but typically our protocol is to say one ear at a time. Okay, so as usual, there's some really good questions here, and I don't get to all of those. If I could ask one favor of you, I hope these are valuable in that this is a field where we have a lot of data and a lot of experience. We can't answer everything, and if I can, I will tell you directly that I don't know. I can make a guess, but I'll tell you it's a guess. But I'd like to see if there are others of these that will be helpful to you. I think one of the ones that I mentioned is, what's the difference between an implantable hearing device and a native ear canal? That might be a good one. But if you have a question, if you've done your research, you're looking around and you're like, I can't find an answer to this, that would really help me to know something you would like to see or hear. You have the email address there. I'll stick that up again, just so in case you didn't get it earlier here. Thank you very much for your attention. I'm sorry if I didn't get to your question as time goes by. We'll look through these, and sometimes we can answer them by email. We're happy to correspond to you. Last thing I'll say is that what I like to do is to get the Hear Map stuff together. Then I like to have a Zoom call with you as a family. Typically, we schedule those for 30 minutes. And I'll go through with you what we see, what the chances of success are, and what the options are. I'm astounded how many times there are different options for patients. When I first started this, I thought it would be sort of cookie cutter, everybody would get the same thing. That's not the case. So it sometimes takes a discussion like that with customized advice. We don't charge for those evaluations. I'm happy to do that even if you have a surgeon in your home country that want to use, but I would be delighted to be of service to your family. And again, thank you for your time with us, and I hope your day goes well, and let us know if we can help you. Take care.